There is I gotta be careful. There's a culture problem in our country. If you're seeing me, there's a good chance it's the worst day of your life.
How do I know I'm seeing a good surgeon? How would you answer that? Welcome back to What Can We Get Into? Dr. Nicholas Ferraro, welcome on.
Thanks for having me.
Tell us about yourself.
I'm a neurosurgeon here in the DFW area. I've been here for almost 7 years. 41. Yeah, 41. It's nice when you have to start thinking about how old am I?
You have to think about it.
Yeah, started about my mid-30s. And I do brain and spine surgery. I grew up in Southern California, was there for about 15 years, moved to Texas, and then was here for college, med school. I went to Miami for residency. Was there for 7 years, and then I came back to Dallas, and I'm happy here. I like it here, and now I'm here.
How old were you when you knew you wanted to be a doctor?
I was third or fourth grade when I knew I wanted to be a neurosurgeon.
Did you come from a line of doctors?
No. My dad, so my grandpa was a doctor. He was a hand surgeon, and then he got in a car accident, developed post TBI epilepsy, and decided to go back to residency to be a pathologist. But I was never exposed to it. I mean, I just kind of knew that he was a doctor, but he was like one of those grandpas that, lived far away. You might see him once every few years. So my mom was a nurse, but most of my family is like in law. Like my dad is a former federal prosecutor, former federal judge. My brother's a lawyer. My cousin's a lawyer. There's a lot of lawyers.
So you broke the chain.
Yeah.
What interests you about neurosurgery?
Now everything. Yeah. When I was younger, it was just, I thought the brain was really fascinating. And then, everyone was like, it's hard to become a neurosurgeon. You're probably not going to be able to do it. And so anyone that tells me I can't do something, I'm going to do it just to prove them wrong. And so I'm pretty stubborn.
I love that. My brother-in-law is in med school right now, and he wants to be a dermatologist. And I didn't realize how competitive dermatology is. Yeah,
for American grads, at least when I was applying for residency, American grads, plastics, like categorical plastics, which means you go right into plastics, that's all you do, and derm are, I think, the hardest to get into for American grads. If you take American and international, it's neurosurgery. But most American people don't want to do neurosurgery just because it's such a brutal slog of a residency. How long,
once you graduate undergrad at 22, how long until you're fully on your own, you can do procedures without anybody
I was
attending?
35.
Say that again, you're 35?
I was 35 when
35.
I graduated, yeah. So it's a 7-year residency.
Yeah, that's a long time.
It is.
Are there any that are longer than that?
No, there's no residency that's longer than neurosurgery. There are like combinations that can get you pretty far. I think the only combination, like to have, like you can do like a bunch of different fellowships of being training forever and things that aren't completely related. But I'm pretty sure, I think PD cardiothoracic surgery, that whole timeline is longer than neurosurgery, unless you do neurosurgery and you want to focus on vascular and you do a combined endo and open vascular fellowship. That's going to get you out to probably 10 years, 11 years.
Wow.
After med school.
What's the first case where you were like, oh man, it was almost something that scared you or something like that?
I had to think about that. Residency, you're scared about stuff. But when early on in your training, like what you do is you kind of get the OR ready. You'll position the patient. If it's a craniotomy, like for brain surgery, you put them in pins and so that is nerve wracking because you wait for the attending to come in or the chief resident, and to verify or that you didn't do it right, and then and to show you how you did it, how you're supposed to do it. But probably the most nerve-wracking is going to be when you're on your own for the first time.
Can you remember that?
Oh yeah, and it was a simple case. It wasn't like it was something I'd done hundreds and hundreds of times in residency. It was straightforward. It was just a ventricular peritoneal shunt for a person that had hydrocephalus, and those are very straightforward cases. They're not hard technically, but it's you. Like there's no one you call. It's you. And so if you get into trouble, which you can on simple cases, that's like you're the boss.
You're the boss.
And so that's the scary part, I think.
That I can see how that would be scary. Everybody asked me when I first did my first adjustment, like, were you scared you were going to hurt the patient? I'm like, I didn't push hard enough. I didn't push nearly hard enough to get anything accomplished. So it's interesting to hear your perspective. Obviously, the side effects or the downsides with what I do are obviously a lot less than you making an error or a mistake. So that's interesting to hear that. So what is the most common procedure that you do? You mentioned that the first one you did was something you'd done 1,000 or 100 times. What is the most common thing that you do now?
Spine surgery. Just probably like a ACDF. It's probably the most common.
Okay.
Anterior cervical discectomy infusion for like a herniated disc or like axial neck pain from arthritis. Private practice neurosurgery is around 70 to 80% spine, and then 20 to 30% brain. As a neurosurgeon, and if you do private practice, not in academics, you can do this in academics too, but you could only do spine. Like there's enough spine out there to where that's all you do.
Right.
It's almost impossible to do only brain in private practice. So that you really will only find that at very, very large like private neurosurgery groups where the spine guys don't want to do brain and they give it all to one brain guy, or you see that in academic programs where they have med schools.
What do you prefer, brain or spine? Brain.
Yeah, 100% brain.
Why is that?
It's what I fell in love with when I was young. And I mean, I looked down on spine a bunch when I was in residency because it's not nerves, it's bone. Like I'm not an ortho surgeon, I'm a nerve surgeon. And so I never really got into it. I like spinal cord tumors. I like doing vascular lesions in the spine. I like doing peripheral nerve sheath tumors like schwannomas, and then just brain tumors. I don't do vascular. Everything's kind of shifted more towards minimally invasive endo, and you have to do a fellowship to do that. So that's one reason why. And then just the resources you need for vascular. You really need to have a very, very strong intensive care unit that has substantial experience with postoperative vascular patients or hemorrhagic patients that come in with like an aneurysm bleed or AVM bleed. If you don't, you're going to get in a lot of trouble in terms of bad outcomes because you need that high-level experienced nursing and ICU attendings to really kind of be on point.
Interesting. You mentioned peripheral. Do you do a lot of peripheral?
I don't do a lot of peripheral, but I'll do carpal tunnels. I'll do cubital tunnel releases. I had a pretty good peripheral nerve experience where I trained, and we would do nerve transfers. I do like nerve tumors, but as time goes on and gets further out, you're like, I'm not going to risk doing a complex, even though I did in residency. It's been 7 years. I'm not going to do a brachial plexus nerve transfer when UT Southwestern's in town, and I can send to the plastic surgery department there, who's like one of the best for brachial plexus in the country.
I've been hearing a lot of people with pituitary tumors recently. Why do you think there are so many people that have those? What do you think the cause is and why I'm hearing more about them recently?
I don't know why you're hearing more about them. There isn't, that I know of, any increased incidence of pituitary tumors. I actually saw a young patient today with a small tumor in her pituitary gland. I wouldn't be able to give you a good answer. Most of them, almost all, are just benign tumors, and just like any benign tumor, it'll arise just from some mutation.
Is that a procedure you do?
Yeah.
Okay.
Yeah, you do endonasal. You go through the nose up to the skull base, and I have a ear, nose, and throat doctor that do the approach and kind of get everything ready, and then I come in and take the tumor out.
Interesting. What percent, so if someone has that with vision loss, what percent of patients will have the vision return? Is it time of compression on the optic nerve?
It's usually time of compression, how big, how much. if you have like an apoplexy, where you can have, sudden, essentially a stroke in the tumor that causes it to rapidly expand or it bleeds into it. That sudden pressure on the optic nerve, the optic chiasm, can result in permanent blindness if you don't take it out within like 24 hours. Over time, the brain and nerves have a pretty good means of being able to adapt to kind of compression that's there for a long time. It's that quick, sudden that the nervous system does not adapt well to, and so if it's been a long time, it really just depends on what the preoperative like neuro-ophthalmology evaluation is. If they have severe vision loss, they're not going to get it all back. But if it's just minor, then it'll come back.
Interesting. When we talk about vision loss, the ones that I've talked to primarily have peripheral vision loss. Yep. That tends to return quicker than the central. Is that what you're seeing?
You don't necessarily have, so the peripheral is just because it's called bitemporal hemianopsia, and it's because of how the nerve pathways run and where the pituitary gland is as it comes up, it hits the optic chiasm. And the optic chiasm, it has essentially the nerve fibers that control your temporal visual field, so out there. And so that's why you get the visual field cuts. If you don't, the sudden increase in the pressure and the compression on the chiasm from like apoplexy, that can cause you central more visual loss. But most other like monocular blindness are from other reasons. So you like to have complete and total visual loss, you'll have like a small little stroke, like a clot that goes down one of the arteries that supplies the retina and so forth.
Interesting. In terms of spine, that's obviously something that I am working with more than brain. I don't work in brain at all, but most patients that bypass what I can do for them will send them to pain management or send them to a surgeon. Their number one question to me is, how do I know I'm seeing a good surgeon? How would you answer that?
So I'm biased. I'm a neurosurgeon. But I mean, I'm always going to recommend you see a neurosurgeon over an orthopedic spine surgeon. That difference in training is substantial. Orthopedic spine has very little training in the spine before they're allowed to go out and work on their own, whereas neurosurgery it's half of our residency. Orthopedics has minimal spine in the residency, and then they only have 1 year of fellowship. So that, and in addition, we're complete spine surgeons. I operate on the bones, the joints, the nerves, and the spinal cord. So any complication that arises, I fix. They don't fix all their complications.
Interesting.
And so you'll see that a lot. You'll see that guy with Will Zalatoris. He's a professional golfer. He had a microdiscectomy by an orthopedic spine surgeon, and he had a CSF leak. Well, he went back to the orthopedic spine surgeon, and his response was kind of, maybe you shouldn't be a pro golfer or something like that. And that's the complete wrong response. It's you go in and you fix it. And so it's just a straightforward answer. You open them back up and you go and you find it, you fix it. I've had multiple patients who have had the same thing happen, and they come to the office and they have, a big collection of CSF on the scan, and they say, well, the guy said there's nothing wrong, or, kept offering me different treatments that weren't working. And it's like, well, the answer is you go and you fix it. And that shows the difference between neurosurgery and orthopedic spine surgery.
Sure.
Is, you may have a handful of ortho guys that do fix it. Maybe they did a fellowship at a program that has really, really good interaction with the neurosurgeons. And so the neuros guy would have them in there, and maybe they let them close stuff, like if there's like a CSF leak. But that's not, you don't want a CSF leak, that's a complication. Whereas for us, like, we open the dura on purpose to operate in the spinal cord or the nerves. If we're just doing bone surgery, we don't want to see a CSF leak.
Yeah.
But if we cause them on purpose for different procedures, we can close them. When we do it it happens inadvertently.
I think the reason a lot of times this comes up is the idea of over surgery versus necessary intervention. Mm-hmm. Where do you draw that line?
I mean, you follow the guidelines. The societies have published, like the American Association of Neurological Surgeons, Congress of Neurological Surgeons, the American Association of Orthopedic Surgeons, North American Spine, NAS, North American Spine Surgeons Society. They have all the guidelines published. And so it tells you, like, this is what they have. This is the workup. This is what you should do. And my philosophy is always conservative. Like, I can't hurt you if I don't operate on you. I'm not saying that I hurt patients all the time when I operate. I have very low complication rates. I have good outcomes. But you have to be selective of who you operate on. And I don't think that there is a way for patients to be able to know unless they talk to a bunch of people who've had surgery by that surgeon. A lot of reviews online are fake. If you see people who have like 100 5-star reviews, they probably paid for a lot of them. Especially if you have no bad reviews. Yeah. Like, it's just, my specialty is filled with very, very socially inept and arrogant people, unfortunately. And you're not going to have that personality and not have 1-star reviews. Like I said, if you don't have 1-star reviews, something's fishy.
I've never looked at it that way. That's pretty interesting. I like that you said conservative. When I first moved here a year ago, I had a doctor tell me that DFW has the highest fusion rate in the country. Is that a true stat?
That I wouldn't be able to tell you. There is a lot of things about this area that's very unfortunate when it comes to spine surgery.
What do you mean?
So I have to be careful. I can't name institutions or people, but there is such a concept or practice in Dallas-Fort Worth. I'm sure that happens in other places of the country, but it's very prominent here, to where it's called a pod, a physician-owned distributorship, where the surgeon owns the implants that they put in the patient. They own the screws, they own the grafts, they own the rods. If they don't own it, the primary care doctor who refers them patients owns it, the pain management doctor who refers them patients owns it, or a family member owns it. And there are certain hospitals within this area that are known for being the pod hospital because they're the ones that allow the doctors to do that. And so you're going to have a substantially higher rate of fusions and length of fusion constructs. So you're going to include more levels, probably because you make more money. And anyone who says that doesn't happen is a liar, because we're all human beings. We all have financial pressures. Many doctors have family members that spend their money and they have bills they have to pay. And if you're looking at an MRI and you see 2 levels that really actually do need surgery, but there's one above it it's questionable, you're like, maybe, maybe not. It's a soft call. If you do a pod, you're probably include it.
Is this why you went out on your own and started your own practice?
No. I worked for Baylor. I worked for the hospital group, and they won't allow that. No hospital will allow that. Like, it's illegal. I mean, it's a kickback. It's a violation of federal law. And so, but two, I think it's horrible that you as a doctor would do that.
No, I know. I agree.
And what's even worse is a lot of the companies that they use are they're local. They have proprietary technology, which means you can't get the implants out unless you actually have the instruments that were used to put them in. And I've had numerous times where I'm operating on patients, and they had a pod surgeon do the surgery before, and I go in to take the instrumentation out, and you can't. Like, you have the universal, so the companies will make universal removal sets. Well, you can't get, because there's a proprietary lock or something that prevents you from getting the stuff.
It's like a lug nut key.
Yeah. And so you'll call the rep, and what it is the reps that for the pods are employed by that doctor. And so you say, hey, we need your set. Sorry, we're not going to help you. And,
Wow.
and so now you're stuck in the middle of the OR. So you got to use metal cutters, cutting this stuff out to do the surgery. And it's just why, as a physician, would you ever think that that is okay? And you go and you look a patient in the face and be like, I'm here to help you. It's just, So I think that is probably a reason for a higher rate of fusions in DFW.
Interesting. What percent of surgeries are you fixing versus first time surgery for the patient?
I'd say probably about 30 to 40% of my patients are revisions.
Really?
Yeah, I don't mind them. You know, where at Jackson Memorial Hospital, University of Miami, where I trained, that's a spine powerhouse, and I got very, very good at revisions. There is something that, well, I don't want to say very. I got very, very good. I'm very used to them. Like I've just done so many massive revision surgeries that I know. I know how to get where I need to get. I know how to get the stuff out and put new stuff in while minimizing risk. And I also am a firm believer of sometimes I just have to tell you, you don't need more surgery. Like it's the last thing I want is to like, oh, I can fix you. And then the patient wakes up I'm like, I'm worse. Like I'd give anything to go back and not have that surgery. Like that's like, for me, that's devastating. Like I just made your life worse and I can't undo it. And so every day that you wake up, your life is worse because of me. And that's something that weighs on you. Like it weighs on your conscience, your soul. Like it sucks. But you know, if I have patients, I remember one patient came to me at my old job and they had 13 spine surgeries. They were essentially fused from their neck, like the top of their neck to their butt. I think it was like C2 to the pelvis. And the guy was just a poor guy. You see him hobble in, he can barely walk. You know, every step you can see him in pain, and you look at him and it's like, man, I can't help you. And you know, the question I asked him that was really, you know, kind of enlightening for him was there ever a surgery that you had of all the 13, were you ever better after it? And he thought about it for a second. He's like, no. Now that I think about it, I never got better after every surgery. And I looked at him and says, well, like I'll be honest. I can promise you, I'm not going to be different than everyone else. Like what's done is done, and I can't undo that. And it's incumbent upon me to tell you that no other spine surgery outside of like doing a stimulator, a spinal cord stimulator, is going to help you. And so I think arrogance is a lot of the problems in neurosurgery and medicine in general. And you just have to realize that you can't fix everything. And sometimes the best thing you can do for a patient is keep your hands off them.
I love that. That's a great quote. Being in Dallas with obviously the history of Christopher Dunch, how often does that come up with patients?
I'd say at least twice a year.
Twice a year?
At least, yeah.
I probably would have thought more, but
yeah, it was probably more like closer to the actual time. Like I got here.
And that was probably right when you were coming out of school?
I don't remember. So I was in Miami. That place was so busy, you know, 110 hours a week for 7 years. And you just like, I didn't know about Dunch. I never heard about Dunch until I came here for my interview for my job. And the head neurosurgeon for, you know, Baylor in Dallas area asked me what I thought about it. I was like, who is this person? And so there's that D magazine article. I went and I read it, and I was nauseated. Like it made me physically nauseated. I never listened to the podcast. I never watched the series. Like I just have no.
Probably a good idea.
Yeah, it's because it really paints neurosurgery in a light that is not accurate.
Sure.
Where it is accurate, in my opinion, is the culture of academics. Academic neurosurgeons are politicians. That's all they care about are themselves and power. And he should have never been graduated, ever. There were signs throughout residency that he should not have been graduated. And I can guarantee you, I mean, I don't know firsthand, but I can guarantee you just from the personalities of academic neurosurgeons and seeing how things are at other programs, they pushed him along because they don't want to fire someone in residency because of the paperwork. And it's like, you're just like, oh, let's just hope he does okay. And then out of sight, out of mind. And so I was like, you know, there are other things I could go into, but I won't for my own sake. But yeah, it's, I think he did a couple hundred cases in residency from what I remember from the case. And he went to Memphis, which is an operative powerhouse. Like Memphis, you know, I interviewed at Memphis, and I was impressed with what they had available. Memphis sucks. Sorry, but it does. It's just not a desirable place to live.
It is not a great city.
Yeah. But that program is known to make great surgeons. And it's shocking to have that. I mean, it's a Semmes Murphy clinic. Like Semmes Murphy is one of the oldest neurosurgery clinics in the country. I think it was maybe Semmes was a pupil of Harvey Cushing. So like very historic program. And well, Harvey Cushing is the father of American neurosurgery. If you didn't know, or
I did not
people
know
listening didn't know who that was. And so, yeah, I don't have an answer, but I mean, I'm kind of the opinion that he should not have been sentenced to life. He should have been in a lot of trouble. But I think a majority of that punishment should have been handed down to the faculty that were responsible for graduating him.
Interesting. A lot of the show, and I don't know the exact cases, but a lot of the show and podcast focuses on, you know, him having sort of this murderous personality to where he would do these procedures, patients would come back worse, and he was almost like, I'm perfect. This couldn't have happened. So he had this infallible personality. I don't know what percent was incompetence and what percent was his infallible personality, a mixture of both.
I think I would give probably 85, and this is just me pulling numbers, it's not scientific, this is my opinion, 85% of ignorance, incompetence, 15% personality.
The show reverses that. I know you haven't seen it. The show makes it seem like he has all the qualifications, but he has this sort of, I don't care that I put a pedicle screw there in the soft tissue. That's where it's supposed to be. Like he believed what he was doing versus like, I didn't realize.
Well, no, that's incompetence, because I don't care how arrogant. If you're arrogant and you care about being the best, because that's what arrogance is in my opinion, arrogance is when you can't back up your confidence.
Right.
Like Tom Brady isn't arrogant; he's confident because he earned it. Like he can say things about a quarterback. It's like, you're not arrogant, man. You're the best ever. You know, but the people who are arrogant are those who suck. But they just boast. If you put a pedicle screw in soft tissue, if you put an inner body in the psoas muscle, and you see it, you fix it. Like you fix it. The other thing that makes me know that it was incompetence is when he did the ACDF and he aborted the procedure because he found a throat tumor, and he like sutured like a lap to it, a sponge to it, and closed. Well, you don't ever do that. Like, you don't ever leave anything like that in the body, no matter what, just ever. But two, it was an omohyoid. You know what the omohyoid is? Like, it's basic anatomy.
Yeah.
And so he didn't even know that. And this is what kind of goes back to why the whole difference between ortho and neuro. Like, I was at one of the busiest spine programs in the country for neurosurgery. Jackson Memorial Hospital is the largest county hospital in the country. And, we had one of the most sought after spine fellowships in the country. I would argue, others may disagree, but I would argue that we're second to no one. There are programs that are as good as we were for spine, but I would say in terms of spine training, I don't think we were second to anyone when I was there. And like it took me 2 years in the OR of being like, okay, I know what I'm looking at now. Because when patients are there, they're not in the OR because they have normal anatomy. They're there because the anatomy is abnormal. And so like you're there like, watching, learning, and you're looking like, what's that? I don't know, like, you know what it is, but like, you don't. Because it's all overgrown, or it's fractured, or there's a tumor that's eroded the bone, or there's infection. So you have all these reasons why you're looking at something that doesn't match the textbook. And it takes, hundreds and hundreds and hundreds and hundreds for you to be able to see the patterns and difference of patterns and be able to know what that means, and then go in and be like, okay, I know what that is. But then not only do you have to know what that is, then you need to know what to do with it. How do you get there? How do you get around it while preserving the tissue you don't want to hurt, while preserving nervous function, while maintaining spinal stability? And if you don't maintain spinal stability, how do you then restore spinal stability? How much do you do? And like it's that kind of fact is what, combined with what, he did, means that he had no idea what he was doing. Like just like no clue. It wasn't like he put an inner body a little lateral, or he had a vertebral artery injury, or something that happens to the best neurosurgeons that there are. Like if you do enough cases, you're going to have a certain complication. It's just inevitable. You'll have aberrant anatomy. You have a bad day. Like that's the thing. Pitchers have bad days.
Right.
Golfers have bad days. Surgeons have bad days. Like we do. Like you get as much sleep as you can. You do all this kind of stuff. But some days you just have a bad day. And, pray to God it's not an OR day. But sometimes it is. And if you have a bad day, you pray to God. If there's a complication, it's small. And it's not something that's major. Or you are on call. And you have a major case the next morning. And you get called in to do an all-night trauma. And you have another 8-hour case to go on. Like so. Complications happen. Like some of the best neurosurgeons in the world have had some of the worst complications. One, because they do very complex cases, but that's just a matter of fact. You know a good doctor not by do they have complications. They do. You know it by the rate of complications, the rate of major complications, and then what do they do afterwards?
Right.
How do they manage that complication? Do they ignore it? Do they sweep it on the rug? Do they tell everyone else they don't know what they're doing? That, no, that's not true. Do they lie? Do they document falsely? Or do they show up, admit what happened, say, I'm here for you day in and day out. Do they come in, do they show that they care? Like, does that patient matter? And he didn't do that. He quadded his best friend. And quadded means you paralyze some of the arms down. It's a quadriplegic.
Yeah.
But we'll say quad. And he quadded his best friend. Didn't order an MRI after the surgery when he knew he wasn't moving, and then he went to Vegas. Like that's
wild.
That's a psychopath. Like
it is.
And so that is the personality part that plays into it. It's things like that I think are why he should have a serious sentence. Life in prison is a little excessive, in my opinion. Maybe 40 years, maybe 50. Maybe let him get out when he's 80, 70, something like. I'm not a judge, so it's not my place to dictate sentence. But that's the disconcerting thing.
Why was it so hard for the hospitals to put these pieces together? The show made it seem like he was bouncing around between so many different jobs that they couldn't put the pieces together until some of his colleagues had done enough revisions or had seen enough of his work that they were the ones that were complaining to the medical association and board. You've obviously been in this field for long enough. Why do you feel like they couldn't put the pieces together sooner? When did they not track your success and complications rate? Or
they do. You'll have peer review or med review committees, med exec committees that if you have complications, they'll review your case and ask you to kind of opine on what happened. if you have enough of them, they can suspend your privileges. They can put you under monitoring. They can ask that you do some remedial work, like continue medical education in that topic. They can revoke your privileges. There is I got to be careful. There's a culture problem in our country. I'll make this more broad. There is an absolute total corruption of our culture in this country. It has substantially decreased quality of everything. This extends up to hospitals and hospital administrations. Everyone is all about convenience. They don't want to put in the hard work. They don't want to do more paperwork. They don't want to make themselves legally vulnerable to a lawsuit by a physician that's upset, who thinks that they were unjustly punished. And more so, our society has become so obsessed with money and materialism that people will turn a blind eye for money if you make them money.
It's pretty true. It's an interesting way to put that.
But that's not just in medicine, that's everything.
It's everything.
But yeah. that culture infects everything.
100%. I would agree with you. Let's switch topics. How do you balance the art and science of surgery?
Man, it's hard to. I mean, I'm young. I graduated residency in 18, so I'm almost really about 7 years out. It's hard for me to really be able to opine on that because there's gonna be a lot of people who are older than me. Because my answer is experience is art. Like knowing when you were wrong and learning from your mistakes and allowing that to impact your judgment. That's the art of medicine. But yeah, I know what the studies show. I know what the guidelines say, but I know that that's not true here. And so, there have been a lot of situations where I've been able to do that. But there's a lot of situations where I haven't because, you follow the algorithm. And that's what I don't like about medicine is this algorithmic. You turn your brain off. You're like A then B, B then C, C then D. And, algorithms are there for people who don't know. Like it's to help people who don't have that base of knowledge to, make their way through the maze, like a very complex maze. But once you have that base of knowledge, you shouldn't be relying on algorithms. Like, what the answer is. Like, you know what to do. And then to the next level is the art, where it's like you can you have more of a worldview of the things, and you know how to manipulate stuff, or you know how to. You can make complex simple.
I like that answer. I didn't know where you were going to take this, so I was honestly curious how you're going to take that, but I like that. Making something complex simple. That's awesome. I love that answer. That's a great answer.
You get rid of the noise.
Yeah, that's true. How long do you think that takes? They say 10,000 hours. You could do the math. You were working 110 hours a week.
Yeah, well, I would say for 10, I would increase that by 10 for neurosurgery probably. I don't know if we live that long. I have to think about that, but it's just some people don't have as much experience. Like you go to a smaller program where the volume's not high, it's going to take you longer to get there. You go to a big program with really high volume that has a lot of rare stuff, you'll get there quicker. And if you devote more time outside than to kind of learn your skill and your craft, and you go above and beyond, you'll get there quicker. But if you just, kind of go through the day-to-day drudge of work and show up, do your job, go home, you're a cog in a wheel, you're not really going to see the art. Like it takes real dedication. And sometimes it's impossible. Like I admire, and I don't know how they do it, but people who have families. Like if you have a wife and you have kids, or a husband and kids, if you're growing all that, it's hard.
The balance is tough.
How do you? Because you're sacrificing something.
Something's always getting sacrificed.
Yeah.
The balance is the hardest thing.
Yeah, and I don't think there's balance in neurosurgery.
Yeah, I think it's not everybody's cut out for it. Truthfully, do you work on kids?
No. I don't do anyone under 18. Yeah.
My niece had tethered cord, and she went to obviously a pediatric neurosurgeon. I don't know how much do you know about that procedure for a?
Oh, you do pediatric neurosurgery residency. You do a rotation, and where I was at in Jackson, we have the Miami Project to Cure Paralysis, and one of my chairman, he was chairman when I was there. Then it transitioned over because he'd been chairman for so long. He started it, and he's well known for like spinal cord injuries and research. One of the things that he would work on a lot in patients are tethered cords, like post-traumatic tethered cords. And so I have a lot of experience with tethered cords. They're very complex patients. For kids, it's different for the reasons they have their tethered cords. Usually it's like a fatty phylum or something like that. But for the adults, I have more experience with the adults than with the kids. And I couldn't stand peds in med school, but that's just like, no. That was not a field I was interested in for like regular peds, but pediatric neurosurgery they do a lot of really cool stuff. Yeah. It's, especially the craniofacial, like when they work with the people who did it at Miami Children's, and then I think it became Nicholas Children's, but there we did it with ENT, and ENT, they can do like aesthetics and they can do peds. So we would do it with the ENT docs, and they'd go in and reconstruct the face, and we'd help with like doing the craniotomies and removing the bone and stuff. And man, it's just like, it's so cool what they do. But yeah, I don't like doing kids because it's sad. They have their whole life. For the most part, with adults, on average, most people kind of brought it on themselves. You're a smoker. You're doing drugs. You're drinking and driving. You do CrossFit, so you have a lot of back or neck pain. Or you're in the military, you have a lot of back or neck pain. All these kind of things, and so it's like it's different. Like we're here to help you, but it's kind of like you kind of knew this was going to happen, and it did happen. Or then you have the other ones where it's people who die suddenly from brain bleeds that are young. That's very sad. And then most people who get malignant brain tumors are older. And for me, it's not like it's sad. If you're like in your 50s or young 60s, that's sad. Like you still have a decent amount of life ahead of you. But when they're like in their 70s, 80s, and you have a malignant brain tumor, for me, it's sad for them. It's sad for the family. But we all die. Everyone dies, like everyone. And so it isn't like the question was, it's not like it's a surprise, like, oh, I'm going to die. Like, they may not think they'll die soon, but they're going to die. And how I approach it with them, and maybe some people don't like it, but for me, for the most part, most of those patients, when I see them, they have family at bedside or in the clinic. And it's like, you look around and say, oh, there's your wife of 50 years or 40 years. There's your 3 grandkids. There's your great grandkids. Like we all pass away, but you won the lottery. You were born in the United States. You were born when you were born. You have a lovely wife. You're still married. Or if you're not married, you're remarried. You have kids. You have grandkids. Like, congratulations. It's hard for them to see that because, like, oh well, I'm going to pass away. But that's the truth, and it's, I'm there for them. I help them through the process, and if they need surgery, I do surgery, and I'm always there for them. But it's always just kind of like an encouragement, like you did well. Congratulations. This is your stop. You hold your head high.
I love it. You made me want to run down a little rabbit hole here.
No way.
You mentioned CrossFit.
Yeah.
What's the one thing you would not do as a neurosurgeon?
Oh, I don't know all of the. Oh, like in terms of like
Just overall. Sorry,
overall. Okay.
I maybe dove into a hole there. Overall, of all the things that you treat, what's one thing you would not do or you would advise people to not do?
Oh man, I don't want to say this. I'll get in trouble. So I'll say it in a story. So one of my faculty in Miami, he's a spine guy. He's a internationally known spine surgeon, and he likes motorcycles. And I was like, Dr. So-and-so, like, you wear a helmet? I was like, no. I'm like, you ride a motorcycle, you don't wear a helmet? He's like, yeah. I'm like, why? Like, I don't want to be tricked and pegged. I'm like, oh, that makes total sense. So I would say riding a motorcycle.
A lot of trauma cases with that?
Yeah, and it doesn't matter how good you are.
It's the people around you.
All that matters is the people around you. And so you're putting your life in the hands of idiots who are driving down the road, staring at their phone and TikTok videos.
It's true.
And that's just
what gets me is the women. I think texting and driving is terrible. I can't get over I see the people doing their makeup with the mirror down.
Mm-hmm.
How? Neither of us wear makeup, obviously.
Yep.
Texting and driving is one thing. You can kind of whatever, right?
You can. Yeah. And
mirror down, doing your eyelashes or whatever. My wife would kill me because I don't know what that's called. But doing something on your face, I can't. That's complete obstruction and distraction.
It is. It's I'm guilty. I will text when I drive, but it's rare, and typically it's when I know someone is not in front of me. But for the most part, I'm just like, I'll wait. The only time I don't wait is if, like, let's say I'm in an emergency and I'm like, I have to the hospital like quick, and I'm getting text messages from the nurses, and they're not answering the phone when I call, and I'll text them, I need this. But yeah, that's really the only time I'll text when I drive.
I've been quoted to say that I feel like chiropractors, pain management doctors, and even surgeons like yourself are going to be very, very busy in the future with the way that 21st century living is going, with iPads, phones, computers, seated sedentary lifestyle. What's your opinion on that?
Yes and no. I think that we will actually probably, although maybe of the population that's alive then may have a higher prevalence of neck and back issues. I think the overall numbers will actually decrease.
Why do you say that?
Our birth rates are dropping. So the boomers were like the most populous generation, to my knowledge. I don't think that
is true.
That Gen X or anyone else is higher, and so the total number of people is going to go down, and so we may have decreasing rates. And then as we get further and further into scientific advances, there may be, like regenerative medicine, there may be some means of preventing surgery. But that doesn't mean that your field wouldn't still be around. Like necessarily, it's will you actually need someone to cut you open and move stuff around?
How do you think AI and robots will change your field in the next decade?
So we already have robots for spine. I'm weird in the sense that I'm exceedingly anti-robot. So where I trained, we train with X-rays. Like you place your instrumentation using X-rays in the OR, and that's kind of how it's been for decades, ever since they started doing instrumentation. Then it moved to navigation, which is where you'll get intraoperative CAT scan or an intraoperative 3D C-arm to do image acquisition when the patient's positioned and you've done the exposure. And you can use like a 3D GPS style device that tells you where your instruments are and the tips are at all times. And so you can, as you place the screws, you can see it on the screen. It's like superimposed on the CT scan. You can see the tip of your screw, going through the pedicle. So am I lateral? Am I medial? Am I too high? Am I too low? And so that I'll use that. In fact, I do use it now because it's a standard of care. If you don't use it and there's a complication, you're going to have a hard time explaining yourself as to why you didn't. Because the lawyer's going to ask, well, why did you do the surgery there? Well, could you not have transferred if it was like an ER thing? And so unless you had to decompress them right then and there for an emergency, there's no good answer why you didn't use navigation. But navigation still requires you to use a lot of your other skills. It gives you more information. It makes it safer. But you still have that proprioception. You still have that feedback. You still have the ability to kind of do different things, like move. You have more freedom. Robots remove all that freedom. They put you down a set path for screws. You just put your thing down the guide and it just goes, you push it in, you drill, pull out. You can't move it back and forth. It's just there.
So there's no finesse to it.
There's no finesse to it. And now after I finished residency, even when I was coming out of residency, depending on where you trained, there were some places where they only did navigation. And so when you're finished training, if you only were taught navigation, you're limited in where you can work. Because not everywhere when I came out had navigation yet. By being able to do it with x-rays, I could go anywhere. I could work at any hospital. Well, now robots are going to become the standard. And the scary thing for me is when we're of the age where we're going to have a higher chance of needing spine surgery, people who are doing our spine surgery are not going to be well trained because they're only going to have place stuff with robots. And anytime you become dependent on a technology, you get worse. Technology makes us dependent. Technology makes us weak. It does not make us better. And so I guess there's an analogy I like to say. If you had like the Navy or Air Force or whatever, let's do it Navy, and they had a new plane out there. They essentially do now, but let's just say that, because I don't know how advanced what the F-35 or F-22 does, but they had a plane where like they go to the pilots and say, hey, like we have a new plane. You press a button, it takes off for you. Press another button, it flies you to the target. Incoming enemy fighter jets, press this button, it'll dogfight for you. And there's a target, press a button, it drops the bombs or launches the missiles. Press that button, it flies you home. Press that button, it lands for you. You won't have the best pilots wanting to fly that plane because they're alphas. And if you're an alpha, you want the competition. You want to prove you're the best. And if you can't prove you're the best, you're like, I'm not going to do that. I'm going to go to something else. I'll find that thing that lets me differentiate myself from everyone else. And so you're going to start. And so what this does is it starts attracting people who shouldn't be in that position. And then when the machine breaks in the middle of a case, the spine, everything's exposed, and now the spine is destabilized because of what you've done already. And now you're like halfway through, you got the rest of the screws. What do you do? Like you abort the case and close, and then carefully position the patient back onto the gurney, admit to the hospital or her to the hospital, and wait for the company to come fix that robot. Could be a week, could be 2 weeks. And so you create all of these problems. And I'm not saying that robots don't have a purpose, that they don't have a function. But when all you have is a hammer, all you see are nails. And so I fear that it's going to create a bunch of really, really weak surgeons. And that's why I look at like the duty hours for residency, where you were supposed to limit yourself to 80 to 88 hours a week in residency. Please. There's some places where you do, but no. Like, you should refuse to go work. Like I was over 110 hours a week. You didn't have an option. You worked. You showed up. You worked. You're sick. Go to work. do your job. People are like, oh, how do you do it? You figure out a way to do it, and you do it. And you look back and say, oh, I did it.
I did it.
It's kind of like how I look at the Navy SEALs when they go through buzz training. Like, I couldn't do that. But you know what? Like, if you want to do something, you won't stop. You'll do it. And it's, and with AI, like, I like AI in certain aspects. It helps me do things so I can devote my time to what's more appropriate. Like, I don't need to spend an hour typing out a note. Just don't. I need to spend an hour with that patient in the room, talking to them, listening to their story, showing them I care, so that they have trust in me. And they know that if something does go bad, I'm there for them no matter what. But if I'm in the room with them for 5 minutes because I got to spend the rest of my hour on that note, they're not going to have that impression. And so if technology is good when you can utilize it in ways to maximize what needs to be maximized. My fear is that we're using technology to minimize what we need to be improving and maintaining at a level of excellence.
I think that's a good point. I think a lot of people are using technology to hide things that they don't necessarily know.
Yeah, my grammar sucks. So I use it to fix my grammar.
There you go. Which is an okay use of it, if you ask me. I mean, it's okay in a grammar setting, but I think it's an interesting thing. What fields of medicine do you think are most at risk of AI taking them over and eliminating a job?
Radiology.
I would agree.
100%. Probably pathology for slides, not autopsies, but slides. I don't see how a computer wouldn't be able to diagnose a disease looking at an image. And psychiatry.
I could see that.
Another question is, does it make a person's psychiatric illness worse by knowing they're only talking to a computer? I think it might, because you need that human connection.
Yeah.
But it's going to be hard to remove the procedural specialties.
It's funny, as I was talking to Dr. Eric Anderson, who's a pain management physician, last week, and we had the same conversation. And he said, the same thing you said. We came up with radiology, which I think is probably top. You know any radiologists? Are they nervous about this?
All the ones I know are interventional.
Okay. Radiologists, pathologists. He said primary care, anybody that's in primary care setting.
I could see that.
And I would add pharmacists. What do you think about that?
Yes. Yeah. Yeah, I honestly, I don't know. It's going to sound bad. I don't really know. I didn't go to pharmacy school. I don't really know how much role a pharmacist has in a pharmacy outside of like a pharmacy tech. Like,
I've always wondered that.
I write the prescription, and then you just like find the bottle and put it in there.
I mean, yeah, I hate to minimize that as well, but I agree with you. It's kind of like if you're checking drug interactions, and if you're there to, I guess, maybe answer questions, okay.
Yeah. I'm not trying to minimize it, but it's just that there are certain things that I don't understand. It's probably more than likely not a slide on them. It's more of a slide on me, because it's just probably more of a statement of my ignorance.
I'm in the same boat as you, Doc.
There's probably a lot of things behind the scenes I know nothing about that they are necessary for.
What's the future of spine surgery in terms of advancements with like disc replacements and things of that nature?
I mean, I would say that's the future, is disc replacement and minimally invasive. So there's already some minimally invasive stuff, but I think now like there aren't a lot of docs that do it. There are some that do it, but like endoscopic spine, like going into the spine with like a small camera and being able to take out a disc or do a fusion through very, very small incisions. There's other minimally invasive stuff where you can do like tubular, where you can go in like maybe like an 18 millimeter tube or a 24 millimeter tube in diameter. Other than that, it's going to be regenerative, I think, as we start kind of getting into that area, and this still is, I'm going to quote unquote voodoo, because there aren't randomized controlled trials. There's not what we would consider as science, or a large volume of scientific publications looking at regenerative stuff like exosomes. People will do like PRP, plasma-rich protein injections for inflammation. So we know a lot of that stuff works anecdotally. We just don't know exactly why. And so once we're able to do more research and hone down on that, I think that exosomes are going to be the future of a lot of stuff. Tumor treatments, autoimmune disorders, inflammatory conditions, degenerative conditions, and just being able to trick our body into tricking itself to become young again and repair itself.
Do you think that they'll be able to use exosomes or something similar to regenerate a degenerative disc?
It's possible. The question is, why does it degenerate? And so the pathophysiology of disc degeneration is, you have cells and proteins inside of your intervertebral disc that carry a negative charge to them. Water carries a positive charge to it. And so so that charge pulls the water in. And when you look at an MRI, if you look at the sequence, like a T2 sequence, the discs are going to be bright. They're going to be like, a very kind of like whitish gray.
Bright white.
Yeah, bright white. Not bright white, but more of a
grayish white.
Bright white is more of like a true like
fat
inflammation or fat. Like if you have a compression fracture, like a new fracture, it's hyperacute. That's acute. You'll see it'll be white. That's the type of white. And as that water content decreases as we age, they turn black. They get darker and darker, and then they collapse. And so when people say, "Oh, I shrunk when I got older," you did shrink. We shrink when we get older because our discs collapse. But the question is, why do those cells and proteins degenerate over time? And it's all going to come back to aging and what's the real source of aging. I don't think we know that. I've never read about it. I've never gone and looked up research of like the actual known cause of aging. If we knew that, I think we'd be able to prolong life a little more.
There's ways that they can measure it with like telomere length and things like that.
And that's where I think, to be honest, that's kind of my thought of age and a lot of disease or your telomeres. Because as you run out of length, you can't replicate those genes at the end, and it gets shorter and shorter and shorter. And so a question I would have is does every cell have the same length telomeres from the get-go? Does every cell have the same rate of telomere degeneration or loss? Or do some have higher rates? Which ones have higher rates? Which ones don't have higher rates? And how does that correlate with disease presentation? Like your back pain and everything, that happens just because you use it all the time. Like if you use a machine or anything, and if you sit in this chair 10,000 times, the fabric and everything's just going to kind of get worn down. That's just force. That's physics. So I understand like that degeneration, but other things, why does it happen? And why can't it be repaired? Why is it that most of our repair, because all of it goes down that TGF beta pathway that's a fibrosing model and not a regenerative normal tissue model? And so that's where I think things will kind of go towards in the future of medicine. It's interesting, but I don't think we'll ever have a cure for cancer. I don't think we can, because it's just the random nature of mutation. That's why you get cancer, is your DNA mutates in certain spots that results in an uncontrolled growth of a cell line, combined with your body's immune system's inability to control that growth. And so it's going to be the interplay between those both. But you know, I've just, I'm not being negative Nancy. It's kind of the Jurassic Park, Jeff Goldblum, nature always finds a way. Cancer will too. It'll just mutate out of the treatment we gave it.
And then certain things you do, lifestyle and environmental, are going to push you into that or out of that. Mm-hmm. One thing I notice anecdotally with a lot of patients that have acute or chronic disc issues, primarily in the lower back, is a lot of times on MRI, I'll see pockets of weakness in the lumbar erectors. Do you see that when you go in and operate?
Yeah, so you'll go in. So how you should dissect when you do the approaches, you should use a Bovie, find the avascular plane, and dissect the muscles off of the spine. You shouldn't take a cob and rip them off the spine. Using a cob is poor form, in my opinion. But you will see, especially in older women, there's a lot of fat there. And there is a very large avascular plane that makes dissection a lot easier. Men who are muscular, younger, there's not a big avascular plane. Like you'll find it and then you'll get out of it. And so what I've noticed though, over the course of the past few years, and just kind of like I say, just like the art where you just kind of start seeing stuff and try and and how I conceptually think about it is the erector spinae muscles are what your body uses to fight gravity. It's what gives the support to every level of your spine. Well, if those muscles shrink and they're replaced with fat, they can't resist gravity as much. Well, that's not going to, it doesn't increase the force of gravity. It just means that now that force of gravity is being placed on your joints and your disc space. And so I've noticed, I see a lot of patients just with back pain. And there's nothing that's like, you're not like, oh man, your back's awful. They have a little bit of, joint arthritis, some facet arthropathy. They have some, degenerative disc disease with some disc bulges, no frank herniations. There's no frank joint effusions. There's no listhesis. But they just have back pain. And it's like, I've noticed that they all have muscle atrophy, which a lot of times is replaced by fat deposition.
Fatty tissue.
And I think that that's a huge source of just mechanical axial back pain that in my mind, would not respond well to a fusion.
Interesting. Why do you say that?
Because anytime you fuse someone, you get adjacent segment disease. And so you're increasing
hypermobility above and below, basically.
Yeah, you can result in hypermobility, but it's any time that you fuse two segments, you're amplifying the forces above and below. The analogy I use with my patients is, if you've ever changed a flat tire and you got to get the lug nuts off, those are really hard to get off. If you use a wrench with a really short arm, man, you got to use a lot of force. But if you increase the length of that wrench arm, you don't have to use as much force. It's physics. Well, every level of your spine, every single one of them, L1, L2, L3, consider a single arm wrench. So every time you move, every time you turn, every time you sit down, stand up, take a step, run, lay down, the force of gravity and the force and the weight of your body are imparted from one level to the other as you move. Well, now when I fuse those levels above and below are now having that force doubled. So you get increased rates of breakdown above and below a fusion. It's one of the risks that you're supposed to tell a patient when you're going to do a fusion on them. Like, this is going to happen. The question is it going to be clinically significant enough to where we need to operate again or you need another intervention? But you will have increased rate of breakdown. And so over time, that can result in hypermobility, and where I think that ties in with the back pain in people who have muscle atrophy is, well, now those forces are increased above and below, and those muscles are also weak up there. So they don't have the ability to really fight. So now you're even further exacerbating that back pain.
I'll notice the same thing in with my patient population. People that tend to have stronger erector spinae tend to respond better to traction, manipulation, any of the therapies. that's my conversation day one with the patient. If I have the imaging, is I can do a miracle job on this disc, this joint. If we keep that fatty pocket in there, that fatty atrophy, you take one step out of my office, the instability will be what makes this chronic versus something that may be more tamed.
Yeah, there's whenever you do open surgery and you go and we dissect the muscles off the spine, they die. You know, like they're not attached to the bone anymore. They shrink, they atrophy. They really serve no purpose, especially in a fusion. Like they're in the middle of a non-mobile segment, and muscles are there to contract so the bones move. They move joints. That's what muscles do. You know, I think it would be very interesting. It's something that I want to do some research in, is muscle sparing decompressions, muscle sparing spine surgery. So you can get that with endoscopic, but where I would go with this is whenever you do a trauma for the head, someone comes, they have a big head bleed from a trauma, or you're doing a certain type of craniotomy, even if it's elective, when you dissect that temporalis muscle off of the skull and then you put it back on, you'll get temporal wasting. So you'll see people who have like this part just kind of sinks in, and then they'll have a little pooch down here because the muscle kind of sags down. There's ways that you can do a muscle sparing craniotomy where you're able to go in and do the craniotomy, dissect under the muscle, do the bony work there, but you leave most of it still attached to the skull, and then when you take the skull off, whereas usually you just take it off and you hand it to the scrub tech and they put it there and you put it back on later, or if the brain's really swollen, you save it for later, like months down the road. But this is just kind of stays attached to the muscle, you kind of flap it over, it just stays there. And so that maintains a lot of some of the bone blood supply, because you should have some. Essentially, I don't have a brain fart for the word, but the bone will take blood supply from some of the muscle. Otherwise, the bone just dies. And so I wonder if there would be a means of how that would affect in the spine. And it might be a dumb idea. It may not work, but it's just something I've thought about. Would there be a way to do spine surgery, do a bigger decompression while sparing the muscle attachment to the bone, and see what happens?
It's interesting. That's why I'm such a big fan of the disc replacements, is I feel like the chance of reoccurrence is obviously lower, and you talked about above and below. Have you noticed that disc replacements have less of a chance of, what did you call it?
Adjacent segment disease.
Adjacent segment disease.
Yeah, they definitely have less rates.
Sure.
Lower rates of adjacent segment disease. As I look at the numbers, I think it's whereas in the neck it's around 25% adjacent segment disease for fusion. The neck over 10 years, and then I think I'm probably going to quote a wrong number, but I think it's around 5 to 10 for discs.
I had a patient in my last practice. She was 38 years old, had a fusion in 2020. I saw her in 24 last year. Comes in, she'd had a ACDF 3 level, and she had been at the practice prior, so I had x-rays prior to the ACDF. Comes in, she's like, the symptoms are the exact same. Obviously, as a chiropractor, ACDF, blindfold one eye, tie the other hand behind the back. Good luck. So I shoot a lateral cervical film on this girl, and she had a osteophyte that was 1.5 centimeters adjacent to the fusion, above and below. 4 years. She was very hypermobile.
Mm-hmm.
Obviously, this is going to happen. How long should it take? Should it take 15 years? Obviously not 4. And what's the standard of care for, hey, I'm going to fuse this. You're 50 years old. You're going to have some adjacent disease. By the time you're 70,
So all the published data that I've read, it doesn't go into that much detail. It's I'm trying to recall what it was, and I don't think it mentioned number of levels. It would matter number of levels because the more levels you do, the higher the rate, the higher the force, the higher the rate of breakdown. But 10-year rate of adjacent segment disease and cervical spine fusion is around 25%. And when they say adjacent segment disease, they mean clinically significant, not radiographic significance.
Okay.
And so I don't recall if it was a 1 level, 2 level, or 3 level. I'm pretty sure the study didn't mention that because it would have been something I would have wanted to know. Surprisingly, I haven't been able to find a whole bunch of stuff for lumbar, but you're going to have a higher rate just because there's more weight.
Physics.
But typically what I tell patients, if you're in your 60s, 70s, probably not going to need to worry about it.
Right.
If you're I'm operating in your 20s or 30s and you're getting a fusion, you're going to need surgery in the future.
I would agree with that. Would definitely agree with that. One thing you did when I first met you is you brought a 3D printed.
Yeah, I forgot to bring that.
Should have brought it.
Yeah, I was thinking about it and I just completely forgot to bring it.
So that's fantastic. How did you learn or figure out or come up with the idea to 3D print somebody's spine from a CT to show them a model? I think that patient education is something I pride myself in, and I also think your outcomes are going to be better if the patient knows and is educated.
I mean, I had that idea in residency about doing that, and to be honest, it originated with brain and like printing the brain, like the brain tumor, and like showing the patient like this brain tumor, so they have an idea of really what you're looking at. And then when I got out on my own, and I was like working with the hospital system, I always had that idea. I always kind of wanted to do it. I started looking into it, and it's not easy to do like 3D segmentation, at least from my standpoint, not having any like computer science background and like having to teach yourself, so over the time it's become a lot easier because now they have programs that let you do it with a lot more help. But back in residency and when I first finished and was out, it was like the programs were kind of still basic, and I was like, man, I don't have time to figure this out. But over years, I slowly figured it out, and I didn't like my old employer, so I was like, I'm not going to do it for you guys. I'm going to wait and do it when I leave. And so I recently started doing it, and patients like it. It takes a long time to prepare the models. It takes a long time to print. I just did one that was like 34 hours to print that one model.
Wow.
And that's because I use different colors for different things. And I think education is paramount. What we do is very complex, but complex in the sense that it's complex for doctors. Like most people don't do, 99% of people don't do any neurosurgery rotations who are doctors. They just don't. It's a specialty that kind of turns off a lot of people. And, if you were in med school, and this may not be true for everywhere, but I know how it is where I went to med school, and I know how it was where I did residency. If you're a med student and you're on a neurosurgery rotation, like during your 4th year, and you wanted to do a neurosurgery rotation, and we, the residents, knew you had no interest in neurosurgery, the only thing you're doing is showing up at 4 a.m., you're printing out the patient list for us, and you're writing down the vitals in the labs, and you're going home. You're not getting in our way. And like we got too much work to do, and you're just going to slow us down and distract us. Sounds mean, but it's just true. So if you're a med student and you want to do neurosurgery, then you're with us. You weren't leaving until everyone else was gone. You're there. You're going to show us you want to do this, and we'd give you responsibilities, like not just vitals. But with that said, most doctors know nothing about neurosurgery. Like it's pretty obvious when you talk to a lot. Like they have no idea what they're talking about. I don't expect them to. They have no training in it. But with that, the knowledge of biology, anatomy, and disease from a doctor that does neurosurgery to a layperson is exponential. They don't compare. So then you take that between me and them, and it's a lot of times you'll sit there and talk to patients, and I'll try to use different language and or different terms and explain stuff, and show them what the MRI and the screens or the CAT scan and go through it. And that they don't have any idea what we're talking about. They're like, yeah, okay. Like they have people say like, if someone goes into like a deep financial conversation with me about macroeconomics and investing, I'm like, okay. Like, I've never done a business course ever. So it's like, you just kind of like nod and like, yeah, okay. I hope
It's interesting that you start your own business.
Yeah. Well, I hired a management company, but I also started my own business to go out and make myself better. It's
throw yourself into you're more of the person that just throws yourself into the deep end. It seems like figure it out.
Yep.
I'm the same way.
A secret swim. But yeah. And so there's no way to know what a scan looks like. They have no idea. I'm showing them that, but they don't conceptualize it. But if I print your spine,
right.
If I color code the areas that I'm going to operate on, if I show you the bone I'm removing, where I'm going to put that graft and where I'm putting the screws in, you can hold it, you can look at it, you have an idea. You don't know everything, but you have a fundamental idea of what I'm doing. And what I do permanently changes you. Like you want to avoid me if you can. Like if you're seeing me, there's a good chance it's the worst day of your life. Because I don't deal with small things. Like I'll do, some spine stuff small, like you get back pain, it's an inconvenience. It's just pain. For some people, it's a big deal, but the reality in terms of life, pain's pain. Like life is pain, so, but it's something that so when I consent you for a surgery and I tell you what I'm doing and I tell you what the risks are, I want to know that you know what I'm doing and that you understand the gravity of what I'm doing and the risk that you're putting yourself under by allowing me to operate on you. Give me the privilege and the honor to do it. But with that privilege comes responsibility. And that responsibility is to educate your patient. If a patient says, after surgery, I had a complication, and I didn't know about that, that's a doctor's fault. That is entirely the doctor's fault. When I have patients that come to see me, and I'm like, well, what'd you have done? I don't know. I had back surgery, neck surgery. It's like, how do you not know? You let someone put you to sleep. You had to have a machine breathe for you to keep you alive. Someone took a sharp object, cut you open, removed a part of your body, and put something new into you. And your answer is, I don't know. Like, I understand that patients may not want to know. They kind of just do what you got to do. But my response is no. I'm going to tell you what I'm going to do. You're going to understand what I'm going to do, or I'm not going to do it. Because that's the equation. It's a doctor-patient relationship. It's reciprocal. It goes both ways.
I agree with that.
Important. Yeah, and there's like I hold myself to exceedingly high standards, and I hold my patients to high standards. They don't have to meet my standards, but they have to meet high standards. Because at the end of the day, I care about my results. I take pride in my work. And I will not let a patient impact those results if I can. If you show up and you have this idea about stuff, and I said, that's not how it is, this is how it is. We're going to do it this way, we're going to do it this way. And you're like, nope. My response is, okay, well, these are my recommendations. I'm happy to send you to someone else. You don't have a right to have me operate on you. Healthcare is, this is going to fit a lot of people. Healthcare is not a right. It's just not. You can get into esoterics about stuff, and that's a different kind of discussion. But in this country, our rights are negative rights. Negative rights mean they preclude action. They're not compulsory in action. And you can't force me to do anything. I'm a physician. I can offer you my services. I want to help you. I want to get you better. But you do not have a right to me operate on you. And so with that, I give my patients everything. I give them my all. But I require the dance to be both ways.
I think it's important. I think people forget that on both sides of the spectrum. I think doctors forget that. I think patients forget that. After all your years of training, what are things you do to prevent seeing someone like yourself?
Don't be dumb. Don't do dumb stuff.
Some of it's obviously going to be, like you said, drinking and driving, motorcycles. What are things you see that are maybe more repetitive or lifestyle?
Man, the things that are repetitive, that are controllable, that I tell patients not to do are really what you just said, like drinking and driving, riding motorcycles, going on ATVs, doing drugs. You get a lot of brain bleeds by doing drugs. Smoking causes cancer, all types of cancer. But outside of those, people will see me for just being alive, and you should enjoy life to a degree. Life is not the purpose of life is not happiness. The purpose of life is not pleasure. That's a very, very superficial way to look at life, and I believe it will leave you fundamentally unhappy and never and always searching for more. But you shouldn't not try to enjoy it. And if things that you enjoy result in you needing a doctor's services, mine or someone else's, but your life would not feel complete without it, I'm not going to tell you not to do it. A stale life is not a life worth living, in my opinion.
I agree. I feel like I'm constantly talking to patients about this because they think that I'm going to tell them not to get on a horse, not to go jet skiing, whatever it be, right? And I'm not that guy. I'm not that guy. Unless you're deliberately doing something, you're a bodybuilder, and I'm trying to help your disc, and you're going out and deadlifting 550 pounds. Okay, you're not helping me help you.
Yeah, it's, and there are some people that like, this is what I do. I'm going to keep doing this. And I'm like, okay, like, I get that, but don't keep coming to me and saying, man, I got to avoid surgery. Like, if I'm telling you what you're doing is going to result in you needing surgery, don't be like, well, I have to keep doing this. And then come back, well, how do I not have surgery? It's like, well, I don't make miracles. Like, I can just tell you what can or will happen and how I fix it. And, I don't mind it when they come to my office and, I'm a surgeon. I love to operate, but it's my job to find a way to not operate. That's just my philosophy. Like, because I know what goes into surgery. I know what the recovery is. I know what the complications can be. So it's my responsibility to try and keep you out of the OR, and only to get to the OR when it's necessary. But, if there is patients who come to see me and like, I'm never having surgery, well, I agree with that, but why are you here? And like, you'll get that. And like, well, I just want to come talk to a surgeon. It's like, okay, well, I'm happy to talk to you.
So do you think they want you to tell them that they don't need it and they need that sort of opinion to make themselves feel better?
I think sometimes it's probably that's there. Neurosurgery is not a specialty or where you want to go talk to doctors because they're all cuddly and nice and
you guys don't have the best rep for bedside manner.
Yeah, I know. What I will say is I have many patients do compliment me on my bedside manner. I have many of them tell me that they've never met a neurosurgeon or a spine surgeon like me. And so I take that, really, that's just one of my things I kind of have the most pride in, is that I do spend a lot of time. Like, I'll spend over an hour with my patients in clinic. I don't have an NP, I don't have a PA, because I want them to know that it's me, that I do care. Like I will go that extra mile to help you. And, it goes back to kind of like what we were talking about, like the robots and the AI and like psychiatry, and like, would it make some of the psych problem worse if they were doing it to a computer? Human touch is so important. Like, just to put your hand out and touch someone else, let them feel your hand, hear your voice, means the world to them. But when you walk in for 5 minutes, say, blah, 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 I'm so-and-so, this is what we're doing, you leave, and the only other person they ever see is your NP or your PA, like, they know how important they are to you. And the response of some doctors, like, well, I have X number of patients I have to go see. They don't care. They just know you didn't spend time with them. They know that every moment from then on is going to be the same. And so it's, I have being present, and that humanity is there. And, going back to the tech, I think the tech is removing humanity from medicine. And medicine without humanity is very scary and not something that I want to be a part of.
It is. The good news, I think in our lifetimes, I think we're relatively safe, but it's heading in a direction.
Yeah, there's a guy that it's not medicine, but the guy that wrote, what's that song? I don't listen to country music, but Richmond, north of Virginia.
I don't know that song.
So he's like some country dude. He plays I think he plays a banjo or guitar, and he wrote this kind of like making fun of all the DC people about how they don't care about like normal Americans. But he was invited to some conference and he gave a speech. And one of the things he talked about that I was like very prescient, and I never even thought of that. And it's patently obvious, but we are the last generation to be alive that knows what life was like before AI.
It's an interesting way to look at it, but that's true.
What's scarier for me, and we've already seen this, and this is me going on tangents and rabbit holes, is so the iPhone came out in 2007, 2008. Never before in the history of mankind, ever, has there been a generation raised where the majority of their human-to-human interaction during development has been through a computer screen, phone screen, tablet screen, same thing. Never before. So our DNA, we know, is influenced by environment and social interactions through methylation. So if the totality of humanity, if our DNA is based off of interaction, touching each other, speaking to each other face to face, looking at each other in the eye, hearing someone else's voice in person, not reproduced through digital electronics, what's going to happen to these new generations when the majority of their interaction through development is not that, is through a screen? And I would argue it hasn't even been 17 years, and we're already seeing the manifestations of it with increased suicidality, increased anxiety, increased depression, increased alcohol, increased drug use, increased other psychiatric diseases that are out there. Like people are angry all the time now. This goes back to my disdain for social media. It's because you're always being aggravated, always, by people who don't care, who don't matter. Like, why do you care what some random person in Minnesota says about you? Not about you, about just what they said about some topic. Or why do you get value from your own life because some random person liked your post or didn't like your post? Who cares? Like, who cares? Like, they matter, they're an important person, but to their family and their friends, they shouldn't matter to you.
It's exactly right. I agree with you.
It doesn't like negate their value as a human being. Everyone has innate value as a human being.
Yeah.
But I mean, it's like, and so that is like, I went down a rabbit hole. Yeah, that's kind of like the stuff that concerns me, and with technology and just this staleness of how science and tech will ruin medicine, I think has already kind of ruined our society and our interactions with each other. And that's why everyone is just always so on edge, so angry. Because, I mean, like, it wasn't like this. I wasn't alive in the 50s. I wasn't alive in the 40s or 20s. But man, if someone came to your door and they needed help, you'd invite them in. You wouldn't like look at the people and say, no. You know, it was just a totally different society.
Different demeanor.
Yep.
Last segment of this podcast is called What Can We Get Into? And we've gotten into a lot today. I love it. What do you do outside of medicine? What do you do outside of work? What keeps you sane? What keeps you balanced?
Man, what keeps me sane is God and my faith, especially in this hectic world. What I do for fun is golf. Like I'm a golf addict, and
Where do you play at?
I'm a member at Craig Ranch, up at TPC Craig Ranch. But before I started this company and gave up all my money to do it, I'd like to go around the world and play a lot of golf courses and baseball. I love baseball. So I used to have season tickets out of the Rangers, and I gave those up to do this.
Are you disappointed by their new stadium?
No.
There's some people that are more like classic baseball outside, sweat it out. Feel like the new stadium has.
Sorry, they're idiots. Like it's just like
they're trying to run a business and they're trying to get people in Dallas, Texas, in August to come to a baseball game.
Yeah, like why don't you go out and I have no interest in going out and sitting in 97-degree Texas, like Dallas summer, in the outfield to watch baseball. That is just dumb. Like you are not proving anything to me that you're tough. Like you can sit out there, you can go have a heat stroke, you can do whatever you want, but some things about technology are nice. Having an air-conditioned baseball stadium for summer months is good. I would hope that if they rebuilt a new football stadium for the Green Bay Packers, it wouldn't be outside. I would hope that they would make it covered, just out of kindness. Like you can, so you should maybe do it. But yeah, I travel. I used to travel around the country and go to all the different baseball stadiums and play the nice golf courses around the stadium. And I will say that the Rangers Stadium has the nicest VIP section I've been in of all the stadiums I've been to so far.
The newer stadium?
Yeah. Like just hands down. Like every place I've been, and I haven't all, but every place I've been does not compare.
Where have you not been?
I haven't been to Mets. I haven't been about probably half.
Have you been to Wrigley?
Yes, I love Wrigley.
Have you been to Cincinnati Reds Stadium?
I have not yet. I've driven by, but I've not been there. None of the Ohios, none of no Michigan, no Canada. I haven't been to Seattle. I've heard Seattle's nice.
Oh, really?
I've been to most of the California ones. I was surprised that San Francisco's is not as nice as, it's nice, but it's really small on the inside. I haven't been to the VIP for Yankees, though. That would be expensive. I imagine that's very nice, but I have not. Fenway's cool. I like Wrigley more.
Who do you root for?
So I grew up in San Diego. I'm a big Padres fan, and I root for the Rangers.
No Miami teams?
No, I'm not a fan of Miami. When I was there, I rooted for the Marlins, but I'm just, I like the beach. I love warm weather, but Miami was not my flavor.
Where'd you live at when you were there?
South Beach.
Okay.
I lived on 3rd and Ocean. I was right on the water. South of 5th. It was awesome.
Wow.
So it was, phenomenal place to train, phenomenal area to live in
Not
terms
that you
of
had much free
beach.
time.
Yeah, you don't, but if it'd be February and I'd be post-call and I'd just go down my elevator, walk out on the beach and text my friends in Minnesota. Hey man, it's 85 degrees here. Screw you, man. It's like -5. That's what I interviewed at Mayo for residency, and I went up there in January because I wanted to see. I hate cold weather. I turn in like Roseanne Barr in a Snickers commercial when it's cold.
That's why I moved to Texas, man.
Yeah,
from Ohio. So,
and I remember I went up there in January. I need to know what it's like during the winter if I'm going to be here for 7 years. And the shuttle guy from airport in Minneapolis, St. Paul, is driving down to Rochester. It was like 27 degrees outside. And I'm in Houston at the time for med school. Grew up in San Diego. I don't do cold weather that much. And he's like, man, it's like, you guys are lucky. Like, you're here on a warm weekend. I'm like, looking at him, I'm like, dude, there's like 3 feet of snow on the ground. It's 27 degrees. There's nothing. It's like frozen water. There's nothing about this warm. And then you go there, like you see, like on the Mayo campus, like everything's underground. I'm like, nope.
Easy decision for you.
Yeah. It was a phenomenal program. Like, it's like Mayo was very cool, but like, it's like, there's just, and I kind of said that in one of my interviews with one of the faculty. And I could see the look in his face. I'm like, yep, I just bombed that interview.
That's highly sought after, isn't it, Mayo?
Yeah.
Do they have multiple campuses?
They have multiple campuses. They have one in Scottsdale and they have one in Jacksonville, Florida. But the one in Rochester is the main one.
Is it?
And I think Jacksonville does have a residency now. I think one of the faculty from Hopkins went down there when I was in residency to start a program.
Interesting. If you weren't doing neurosurgery, what would you be doing?
I wouldn't be in medicine. Man, I don't know. I used to think about law school, but as much as I hate documentation, I'd be a horrible lawyer because they write so much. So I don't think I'd be good at that. I love to cook. Like, I really enjoy cooking. I could see myself being a chef because there's precision. There's also art in it. It's instantaneous, like, results, and people love it. It's family. Like, there's nothing that brings. There really isn't anything that I know of in humanity that brings together every single culture, religious group, whatever it is, food. Like, that's like, when you think of, when people are like, I've always think, when people are like, oh, I love diversity, or I have to be in a diverse place. They don't really mean I need to be around a bunch of languages I don't understand. They mean I want a bunch of different types of food. That's what you mean, like.
What's your favorite food?
I can't say Italian because I'm kind of Italian. I'm a mutt, but yeah. I'd have to say Mexican, man. I love Mexican food. I've really recently gotten into Thai food over the past probably.
You like spice?
I love spicy, yeah. And sushi. Like, I think it'd be one of my dream trips is to go to Tokyo and do like just a food tour. And
What's your favorite sushi place here?
Shoyo.
Where's that at?
Lower Greenville.
Oh, I know where that's at. Yeah,
it's like a little, I think it's like 11% omakase.
It's omakase, okay.
And it's so restaurant Uchi. I love Uchi. Uchi's good. Uchiba's phenomenal. Uchiko's good. Yeah, Uchiko's, they have one up in, it's kind of closer to where I live, up in Legacy West.
Yeah.
They have the best edamame I've ever had. But the difference there is it's like wood fire. It's a little more meat based, but that's the kind of like where Uchiko is. Uchiba's cool because on the first Monday of every month, it's called Uncommon Ramen, and they'll bring in guest chefs to do their own take on ramen. And so, like, you'll have like chefs that do barbecue, chefs that are like are Mexican chefs. And then I think the best one I ever had was a Peruvian chef. And being in Miami, like, so I don't like Cuban food at all.
Interesting.
At all. To me, it's bland Mexican with plantains and black beans.
You're not wrong.
Really, really heavy pork. There are some, but yeah, I love the pastelitos. That Cubans do phenomenal coffee. Like, Miami does coffee phenomenally well.
They do.
And they do cigars well. One of the reps for one of the spine reps that I knew in Miami, he knew Fidel's former cigar roller. She was up in Hialeah.
That's where my mentor's from.
Really?
He's the only white guy from Hialeah.
Yeah, it's but Peruvian is equivalent of Peruvian. So there's a lot of Japanese people in Peru.
Interesting.
And so I'm pretty sure Peru's where ceviche started. So Peru has like, it's like a mixture of like Argentinian and Brazilian, where you get like the churrascarias and like the very, very beef, like meat based really what you get when you go to Fogo de Chao,
Yeah.
combined with the seafood of like Japanese style.
Interesting. Okay.
So they have, I really like Peru. They say the Peruvian chef that did the ramen that I was like, and there was a time where I would go every month for like a year and a half.
Did they tie in the seafood to the ramen?
Well, so for that one, it was, there was no seafood. It was a pork, I believe.
Like the chasu that they do? Or
Yeah, the chassis. But it was the toppings and the seasonings were Peruvian. Yeah. Like these little, like Peru, like have these little kind of, I don't know what to call it, but nuts. Almost like corn nuts, but they're a little different. Yeah, they had those and some other spices in there. Like ají amarillo is a big Peruvian spice. So yeah, I like Peruvian food. But yeah, I'll nerd out on sushi. Like before I went to Shoyo, I bought a book called The Art and Science of Sushi. And then I bought like a super expensive, like handmade sushi knife from Tokyo.
So I thought you were going to tell me you bought like a side of like a bluefin tuna or something.
No. And well, what's cool about it is it shows you how much of a science is in the book. It goes through all the different types of sushi, how to do it, but how you kill the fish.
That matters.
It does. And they go into science of why you do it this way. So like they put a metal rod down the spinal canal and it completely depolarizes all the neurons there because you don't want the muscles twitching. When the muscles twitch, they use up ATP, and the ATP is what you call the umami, the flavor. And when you cut the fish, you need to have different types of knives. And so I bought that long knife because you cut the fish in one slice. Because if you don't, you crush it. And the crushing opens the cells and wastes the ATP.
What in the world did you pay for a knife like this?
Oh, I think it was like $400.
It's just like sitting up on you.
It's just my
Sushi
kitchen.
is one thing I don't do at home because I feel like it's so much work. You dirty up 3/4 of the kitchen. Takes 4 hours.
Yeah, it does.
And then you eat a roll and a half and you're looking at the mess.
See, I don't make a whole bunch. If I do sushi, it's more of like a sashimi.
Sure.
I haven't done like the actual like rolls. What takes a long time. So I'll make my own pasta. Like I'll make my own pasta. Like last night I did like a Mexican dish, everything from scratch. And that's like, I'll just go home and cook and just like I can just kind of go in my own mind and just kind of think about stuff while cooking. And it's like, if I ever retire, I would love to go to culinary school.
I love that.
And just go to be like, I'm going to go to culinary school. Like, and not even like have a restaurant afterwards. If God blesses me in the future with a wife and family, then I cook for him.
Are you a recipe guy or a taste as you go?
Recipe guy for the first few times, then I started doing things on my own. And so just because I want to know what it's supposed to taste like, and then from there I can branch out.
Which makes sense for your personality on how you described science versus art in your surgery.
Mm-hmm. No, and that's how you learn in med school. You learn normal before you learn abnormal. You can't know what's abnormal until you know what normal is.
You look at enough normals. They told us that in radiology. You look at enough normals, the abnormals will just pop.
Yep. Oh, it's crazy. It's like you will just start picking up the most subtle things in the world.
Just boom.
Yep.
Last question. What's your best dish that you cook? You said homemade pasta. If you say what I think you're gonna say, we're gonna have a cook-off here, Doc.
I'd have to say there's probably, I can't give you just one. Either tagliatelle bolognese, which I love. Like I didn't realize how long it takes you to make a bolognese, but I love doing a bolognese. And then that, or like a shrimp arrabbiata. And then I will say, I think probably the best thing that chicken verde and enchiladas.
So bolognese is my thing. People know me.
Really?
Because if I meet you and I invite you into my house for dinner, that's what we have.
Right.
It's my introductory meal. I know how to nail it. There's no variability. I know where it needs to be. It's a long, slow cook. I pull it off when I need to. And it's always spot on.
Challenge accepted.
So I love this. In 30 seconds, tell me, what do you put in it? I mean, what is
man,
it?
I've only done it like 3 times.
You've only done it 3 times.
Yeah.
Oh, this is an easy win.
So
I've done it 100 times.
it's possible. I'm not going to say that mine's better than yours, but so like when I do it, like I go all out. Everything is
Me
from
too.
scratch.
Me too.
Like, so it has veal,
Veal, beef, and
pancetta.
pork. Okay, so you don't pancetta.
and sirloin.
You grinded the meat yourself?
Huh?
You grinded the meat yourself?
Oh yeah. I grind the meat, everything. The cheesecloth, you do egg, you do. It's fun. And then I go and you make the pasta, you do everything. I do it by hand. And well, part of the machine, like when you get it flat,
To roll it.
that's with a little machine. But man, I bought like handmade little pasta cutters from Italy, and like I cut everything by hand, so it's a little uneven, and it's so there's a guy on a Netflix chef's table. There's one chef table's noodles.
Mm-hmm.
The guy, I don't know what his first name is. Last name is Funke, Funke. He has a restaurant in Beverly Hills. He's one of the best pasta makers in the world. And he went over to Italy and learned from all the old grandmas. And he does everything by hand. And like you watch that, I'm like, man, I would just love to be that good.
It's a forearm workout, man.
It is. It really is. And like, I'll break a sweat.
All those Italian grandmas, man, they got some good shoulders and forearms.
Or they have really bad ones and they just live through the pain.
Doc, it's been a pleasure, man. This has been awesome. I think part 2 is maybe a bolognese tasting competition.
I'll do it, man.
Anything else you want to add?
Great. No, I thank you for having me on. I thank you for your patience with past 2 weeks. First having work get in the way, and then last week with me being under the weather. I'm sure people hear me sniffling. But yeah, it's. I really think you having me on. It was a good time.
Awesome. Thank you for coming on.
My pleasure. Thanks.